go ahead and kick us off here. Thank you again for joining us for the Systems for Action Research and Progress webinar series. My name is Carrington Lott, and I'm the Deputy Director at Systems for Action. And we are a national research program office funded by the Robert Wood Johnson Foundation. We've been operating as a national program office for about 10 years now, and one of our main activities is to develop and release annual funding opportunities, soliciting ideas for innovative ways of aligning systems. So aligning the medical, public health, and social service systems. We've funded about 50 projects to date over those annual funding opportunities and over the years all across the country. And so we've been learning a lot about systems for action broadly. But this Research and Progress webinar series is typically a venue for our researchers to come and present multiple times throughout their projects. So you can hear and learn alongside them in a rapid sort of fashion. So you get to hear from them in the beginning of their project, and again, typically in the middle, and again at the end. So you can hear everything that they're doing through the progress of their research projects, depending on how long they are. Today, we have a special session. These are not grantees of the Systems for Action research project, but they are doing some fantastic systems alignment type research. And they're going to be talking to you about their Medicaid Panoply and the process and what they've learned. And I'm really excited to have them here to present to you. Before I hand it over to the speakers to begin the presentation, which is why you're all here today, just a few housekeeping items. These sessions are always recorded, so we will share the PowerPoint slides as well as the recording and any other resources that are shared during today's webinar after this session. And we also save time at the end for Q&A. So if you have a question at any point during today's session, please locate the Q&A box at the bottom of your Zoom screen and pop your question in there, and we'll make sure we save some time at the end to ask your questions to the presenters. We will do our best to see the questions in the chat, but typically we will do a better job of finding those if you put them in the Q&A box. So please try to put them there to ensure that we can ask your question. And with that, I'm going to hand it over to Dr. Hicks and Dr. Craig to present to us today and fill us in on what they've been doing.
Well, wonderful. Thank you so much for the opportunity once again to come and share with Systems for Action. We're appreciative for your entire team for the invitation to come once again. We had an opportunity a few months ago to share with Systems for Action in a think tank, and I'm appreciative for the opportunity we have now to come back once again. I am going to ask Dr. David Craig. He is my research partner. I am Ivan Douglas Hicks. I am a most recent graduate of the Interdisciplinary Research Leaders Program of the Robert Wood Johnson Foundation. I serve First Baptist Church, North Indianapolis, and I'm the proprietor of the AfricaLogical Institute. We are a scholar activist. So thank you once again for having us today. We're looking forward to sharing our research. Dr. Craig?
Greetings, everyone. We're happy to be here today. I'm David Craig. I'm a professor of religious studies at Indiana University, Indianapolis. My main area is healthcare ethics, and I do a lot of work with the ethics of health policy. I'm also an associate director with Community Health Partnerships, which is part of Indiana Clinical and Translational Sciences Institute. So I kind of live at the intersection between kind of academic ethics and then more applied community engaged work around health equity. It's really great to be here today. So one of the things I want to say right at the beginning is that when Dr. Hicks and I say we don't mean the two of us. We mean about 30 collaborators who have worked with us actually on two different studies. Our first study was back in 2019, where we did a study of Indiana's Medicaid expansion, which is called the Healthy Indiana Plan, HIP. And this was very much a neighborhood-based study where two congregations helped us connect to people who were on the Indiana expansion plan called HIP. And we wanted to learn from them as community experts about how Medicaid was working or not working for them. More recently, we just finished an interdisciplinary research leader project with our main PI, co-PI, Elaine Hernandez, who's a medical sociologist at Indiana University in Bloomington. But this is the team, right? Doing community valued research that's action oriented requires lots of collaboration, lots of partnership, lots of trust. And at the beginning of that list is the Community Leadership Board, who represented 5 different cities around Indiana and a variety of community leadership roles. One of our goals with this study was to do research with intended consequences. And we're going to return to this theme regularly as we proceed. So we're going to talk about different sort of intended consequences, reports, or talks, or other ways of disseminating the research with an emphasis on affecting specific systems. So for us, if you're trying to kind of do research that honors lived experience, that collects credible data, that reflects that community expertise, and is driven by moral conviction, you got to have a community leadership board who's not just advising, but leading the study. In addition, we had academic partners who helped conduct 100 in-depth interviews across Indiana with HIP members. There's a quantitative team who was looking at Indiana Medicaid enrollment data, and kind of the list goes on. And importantly, kind of grounded by the AfricaLogical Institute and the team there, a community project manager, people who ran the community leadership board, and whatnot. So we just need to sort of indicate the breadth of the foundation from which we're working before we move to talk about how we try to engage systems.
So thank you, Dr. Craig. Before you now, you see a timeline, and we started this project in 2022. When we started the project, one of the first phrases we gravitated to was community valued research. We wanted to determine how we could listen to, translate, and then amplify the voice of the community, specifically around Medicaid. And our concern with our 2019 Medicaid study was the Healthy Indiana Plan. And so we've been able to look at Medicaid expansion and determined that there is too much bureaucratic hazing, that it is arduous, that communication does not take place for those that need to know more about Medicaid. And even as they go through the process, it appeared as if though there were people trying to keep those that need Medicaid from going through the process to receive it. In the midst of our study of Medicaid and the Healthy Indiana Plan, we always use as a benchmark the legislative session. Even before this study for our work, that legislative session is important because we believe that that the way we know change has taken place is when it is documented, when it's memorialized. And the way that takes place is in laws, policies, procedures, rules, and regulations. Somebody said, if it's not written, it's not real. And so in order to have real change, we not just looked at the legislative session and laws, policies, procedures, rules, and regulations, but as we pressed our way through the Robert Wood Johnson Foundation Interdisciplinary Research Leaders Program, we determined that we would create reports. And in politics, we discovered that people, after they do things, will say, oh, well, there were some unintended consequences. We determined that as public policy was shifting, that we would create reports that have intended consequences. And specifically looking at systems. How can we change? How can we impact? How can we have, in this atmosphere, how can we create a dent? How can we look for the crack or the crevice that we can exploit? But we were able to, in 2024, create a positive economic Medicaid impact report that was geared toward the supermajority, Republican-led General Assembly in Indianapolis, Indiana. That report you can find at AfricaLogical.com. It's a part of the Panoply that you see we've created. But before we created that entire panoply, a panoply are the weapons you use to fight. In 2024, we created this Medicaid Impact Report that had different imagery. It had imagery that would attract and catch the eye of state representatives and state senators on purpose. We were able to present the opportunity to change from five different Healthy Indiana plans and to streamline that into one HIP. We were able to articulate how important it is for people to be healthy so that the workforce is bolstered by healthy workers. We were able to articulate how 90% of the resources that come for Medicaid expansion for our Healthy Indiana plan, 90% of that came from the federal government. The other 10% came from an excise tax for hospitals and cigarettes. And so it's a zero sum proposition for the state budget to advance healthcare, streamlining from many HIP programs to one HIP. The suggestion with that was that we would have an opportunity for everybody to have dental care. Everybody would have eye care. They would have the best available through Medicaid expansion as opposed to the punitive way people were kicked off of Medicaid and reduced in terms of the ability to pay. We were able to say, why don't we, with this specific paper, with this report, why don't we look at the financial implications and the financial impact and understand that actually Medicaid is good for the workforce and good for the state of Indiana? That was an intended consequence that we looked to see how we could write a paper that would be influential for a specific market or a specific audience. We did the same then in 2025 with our Medicaid Panoply that once again is found at AfricaLogical.com. It's a free download. It's an open source document that was created once again with an intent. The intent was to encourage not just other people in other states to be concerned and to fight heinous laws and these political determinants of health that are literally killing people these days. Our intent was to create this panoply that we could share and encourage people, not just with Medicaid, but with other issues, to say that as other people have other notions about what should be taking place as a result of a document that also has 2025 in it, that this one says that we are going to fight on no matter what, that we're going to fight in 2025. And the Medicaid Panoply that we created not just represented what our team did, but it represented what many people around the state did. And so in that Medicaid Panoply, you'll see testimony, evidence, we'll see there's a mini documentary, and we must say that what we've created, this panoply, is multidimensional, that we included art on purpose to catch the eye and maybe even catch the soul of people as they look at research. We intended not to present something that was stale or linear, but something that was multidimensional and that would capture people's imagination and their attention. And so there's art in there. The graphic artist worked extremely hard in order to make sure that we have compelling art. There's poetry, a couple of poems. There's a little comedy in there, but there are different perspectives from different people from different parts of the aisle. And the notion is that we can all do our part. We can use our gifts, talents, abilities, skills. We can use our perspective. All of them are unique. They may be different, but with the problems being so diverse, our opposition needs to be diverse. And we need to make sure that everybody is empowered to do what they can do so that we can all move against such horror that we are experiencing in 2026. So Anyway, the Medicaid Panoply, that was 2025. Now we are engaged in the dissemination, really, of that Fight On 2025 project. And we're appreciative for the Indiana Minority Health Coalition for supporting us in dissemination. That we now have an opportunity, whereas with our project with Robert Wood Johnson Foundation from 22 through 25, we went to 5 cities around the state of Indiana, and we held in-person and Zoom sessions that were about health equity, and specifically our area is certainly Medicaid and HIP. But we were able to work with these 5 cities and health equity workers, and we reached out to the faith community, to the Latin community, realizing that we are not simply trying to determine what attitudes are, but this is action-oriented research, and so we need to communicate. And that was impacted by our ability to garnish or to glean emails from people around the state, so that now we have a large list of people that we have already been in contact with. We've been in dialogue and discussion and talked about health equity, and we're in relationship because it is our contention that there's no way that we can be community if we are not in relationship with one another. And so as we go now not to 5 cities, but to 7 cities as we disseminate, we will continue to ensure that the relationships are established so that that proverbial email or that proverbial phone call that has to go in order to advocate or the lessons that need to be learned in specific cities from the rest of the state, the education can take place because there are channels of communication that have been opened through this research that not only seeks to provide information and glean information, but also seeks to work toward creating the environment so that, once again, laws, policies, rules, regulations, these things can change, because that's when we know change has taken place. And so this team that Dr. Craig has talked about worked extremely hard in order to create a panoply and in order to provide testimony, in order to do what we could do to show everyone that it is possible for us to stand up. It is possible for us to speak up. And specifically for us, our concern is the amplification of community voice. How can we ensure that the community is heard? Specifically, as we looked at this notion of community valued research, and I'll define it a little bit, but I want to stop talking for a quick second and let Dr. David Craig jump in here a little bit and share, tighten up some loose ends if I've missed them, but talk a little bit about community valued, and I'll be right back with you.
So as we think about community valued research, and we're going to pivot soon to talk about how we engage different systems, for us, community valued research really includes 3 main claims. One is that the community or communities have expertise. And as a result, community participants need to co-create research design, implementation, and analysis, right? And then the result of that is what we call appreciation, which isn't just to appreciate what people are saying, but actually, to use the technical term appreciate, to help increase in value the communities that we're working with. And I'll turn it back to Dr. Hicks for that.
Thank you. So, 3 things. Community valued research believes that the community is the source, the community is the expert. That's a Dr. David Craig notion right there. Community is the expert. And so that's the first thing that we acknowledge, we honor, and we accept the fact that in order for us to get the best results, if we're studying the community, that the community is the arena. The vantage point from the community is absolutely necessary if we are going to understand problems, but then also solutions. Not only is the community the expert, but every every iterative stage of the study, from the beginning before questions, as we begin to think about the macro of the study, even down to the development of methodology, through dissemination, that the community, not just an advisory board, but the community leadership board in our study, provided guidance and leadership and direction, pushback that honed and helped us to fine tune the experience that was this study. And so the community is the expert. The community is involved in every step of the project, but then finally appreciation as a result of a goal of the study. Um, when we sit down in the beginning, we determine that we're going to work so that funds come back, so that laws are changed. And when laws are changed, budgets are attached. And budgets are not just moral documents. Budgets let you know what side of town or what interest will receive money. And so appreciation is to increase in value. And so the work of the study is not simply extractive to say, what can we find out? But it is to say, what can we deposit? What can we give to the community as a result of the study that we're engaged in? And so we've talked before about this positive financial impact. This was for the state legislature, and the state legislature then becomes a system that we have addressed, that we have cared to write papers that we've discussed before. Then this panoply that we've discussed, the weapons of our warfare. This is how we fought for Medicaid. We showed you a list of people that worked on it. But if you go through this panoply that I believe is found on page 14 at AfricaLogical.com, there's a button up top, the home page. And so you have the opportunity to click there, find this panoply. Once again, all of this information is available open source. It's our hope that by showing people, the community leadership board and their work, there's an amicus brief that we were intentionally a part of. This amicus brief is found in that panoply, but that amicus brief provides for us. Yeah, that amicus brief provides for us the opportunity to amplify community voice. Here we find in the Rose versus Robert F. Kennedy case that we were able to, along with 65 deans of public health, 67 deans of public health, chairs and scholars from around the country, the AfricaLogical Institute, and the research of Dr. Craig and myself from 2016, we were able to insert our research and once again community voice, so that at the appellate court where this is now in DC, when this case was heard a couple of months ago, the amicus brief was mentioned as current research that once again amplifies community voice. And our belief is that the community should be heard when decisions are being made about their lives. And so community voice was amplified through this amicus brief that's gone through the U.S. Court of Appeals in the District of Columbia. And no matter who wins, we're pretty much assured that this case is going to make it to the Supreme Court. So once again, this is another system that we are engaging. We determined last year that as the world was changing, at least the political world here, that has such effect on the rest of the world now. But as things were changing, that it was going to be important for us not to be um, only concerned with legislation, which had been our emphasis at the State House. But in order for us to have some impact, it was determined that we were going to have some litigative approach. And so we had not just legislative updates, but litigative updates during this session, and determined that we wanted to be a part of some type of litigative action. And that was this amicus brief that once again takes us not just to the legislature, but now to the court system. And so yet another system that we are addressing through our research. And so this amicus brief was important for us. Not only that, but we also have participated in other ways, and Dr. Craig can tell us about some of our more standard or academic uh, approaches to the systems that are in place.
Thank you, Dr. Hicks. So just to contextualize this idea that we're trying to engage systems. We've tried to engage the legislative system. We've tried to engage the court system. There's the academic system, which I'm going to talk about a little bit too. But in each of these cases, when you're engaging with systems, you have to think about that system, right? How is that system operating? What's its history? What language does it speak, right? What are the places where maybe you can make change? So to give an illustration with the legislative system, Dr. Hicks mentioned how there was a supermajority that's Republican, and the context, we have to think about the policy context that's in place. Everyone was talking about $1 billion deficit in Medicaid. So we knew the story was going to be something like, we've got to cut Medicaid because there's a deficit. So how do you begin to respond to that story? You do that by sort of saying, okay, well, let's make a fiscal argument then. Let's not make a moral argument. Let's speak the language of money, if that's going to be the concern. And so that report was able to document things like how little money was spent per Hoosier, $667 per year, for people to be fully covered. So we tried to use that kind of language. But we also wanted to try to engage the history. The Healthy Indiana Plan has actually been pretty innovative in investing in wellness. Let's congratulate the legislature, right, for doing that. And then importantly, sort of highlight the contradictions. We knew that most of the focus, which is happening in the big, beautiful bill today as well, is going to focus on the Medicaid expansion, even though that's not where the deficit was. So the more you can kind of identify the contradictions or the gaps, or the places where credible community voice is really going to make a difference for action-oriented results, that's what we tried to do. Our interdisciplinary research leader program really pushed us to do action-oriented research, right? We had to have action outcomes. We can't lobby, so we're not telling people how to vote, but we are presenting research in ways that really try to influence advocacy to affect laws, policies, procedures, and regulations. And if you want to, so when we did Ground Rounds, for example, we were invited to give Ground Rounds talks by IU Health. This is the biggest healthcare system in Indiana. We were initially invited in 2023 when the Medicaid unwind was beginning. We wanted to kind of prepare people to think about what's going to happen as people may not understand that they have to re-enroll in Medicaid. How can your team support people in these circumstances? Then we were invited back in May 2025 after the 2025 legislative season, and big changes were coming to Medicaid in Indiana. In fact, the changes that are now coming at the federal level, more frequent eligibility reviews and work requirements, were both passed in 2025 in Indiana. And so suddenly, these healthcare organizations are going to have to rethink how they do financial counseling, right? How do you bring people who are Medicaid eligible to the services when you're not allowed to advertise anymore because there's a gag order? Or how do you connect people when you used to do something called presumptive eligibility, and that's basically become very restrictive? So we were trying to counsel this system. How can you work with the patients who you're trying to connect to Medicaid, right, to actually have those services while you're also trying to do the SDOH intake, for example, while you're trying to kind of work through the other systems that are in place? How might your emergency department traffic change as a result of these things? So we're trying to engage systems in terms of, what are their policies, what are their regulations, what are their practices, and how does the research we've done help to influence that? Okay. So that's the healthcare system. Turning to the academic system, we've also given academic papers, right? These may not be the typical places that a lot of you on this call go, though. The American Academy of Religion and the Society of Christian Ethics. I happen to be a bioethicist, so this is useful for me too. But one of the things that we're trying to work with there as well is, why engage the academic system? Well, in my experience, the academic system, what we talk about in the academy, does influence healthcare, does influence public health, and then there's a little bit of a feedback loop on that. So if we can begin to intervene and say, well, the kind of language we typically use, the kind of issues we're typically addressing, really don't address the circumstances of people on Medicaid, then we're engaging that system as well. So the first talk was really an argument to say bioethicists, healthcare really try to protect patient autonomy. But if you don't even have access to the clinical encounter, how does autonomy help you, right? What we really should care about is something more like health seeker agency. And what are the ways that having Medicaid and really helping people, connect to resources and find their path in the healthcare system promotes agency, not just autonomy. And I'll turn it back to Dr. Hicks to talk about the second talk.
Thank you, Dr. Craig. The second paper that we wrote as we concluded our Robert Wood Johnson Foundation Interdisciplinary Research Leaders Program. Not only did we do the American Academy of Religion, but also the Society of Christian Ethics. And in that paper, we were able to look at really the incarnation of Christ. We were able to look to see how, when humanity needed adjustment, God provided Jesus to come. And as Jesus came to this earth, Emmanuel, he came to the community. He came seeking public. Did not run immediately to a cross and die, but spent years teaching, spent years ministering. When he was born, we looked at the manger a little bit. When he was born, he was not born with a silver spoon in his mouth. He was not born isolated someplace in a peculiar palace, but he was born in a manger with people around him. He was born with people witnessing and adding to the narrative of his coming. And so, for Christian ethics to take a look at Jesus and the incarnation of Jesus, this was a way for us then as well to talk about community valued research. And to say that as humanity and the public, as the community needs to be recognized, as we see that in the incarnation of Christ, we also see that in community valued research, which is to say, once again, that we recognize the intrinsic worth, we recognize the value, the importance, the impact that people provide as we go through these processes. And even as we look at systems on today, systems are made up of people and impact and affect people. And so as we look at people and look at the impact that we should and can have by bringing people together and understanding, honoring their intelligence, their input, their unique perspective, the hope is that we are challenging an academic system to say that we are not going to just peek in on a particular situation and extract what we can, but we want to be right there with, in the center of the situation, gathering information from people that are impacted so that we can all together create a path toward a greater future. And that is what we did in engaging this academic system. And there are other ways we have and will continue to engage academic systems to ensure that once again we're receiving the best input. If we know that it is important to glean data and to hear the understanding of, to harvest the attitudes of people within the community so that that community can not just be heard, but can be authors of the next steps toward help and hope and better. Then if we know that it is effective and impactful to engage the community as scholars, if we do not do that, then perhaps we are participating in scholastic malpractice. Because we know that what we are seeking to do is not necessarily going to lead to the results that we claim to aspire to. And so the push in this paper for the Society of Christian Ethics was to look specifically at methodology and how we go about the process of seeking to understand what the community has to provide in terms of guidance and direction. How we package that is important, and then how we amplify community voice, not just so that we might be heard, but the community's voice must be amplified so that laws, policies, rules, regulations, these things can change and resources can come back to the community that's being served. And so, once again, this is an academic system, but we've also talked about the health system. We've talked about the legal system or the judicial system. We've also talked about the General Assembly, the legislature. And so, political systems, these are systems that are being addressed by research under the tag of what we call scholar activism. That we understand it is important for us not simply to engage so that we can learn, but if there are missions, if there are areas for activism and the need for change, uh, I am a part of the AfricaLogical Institute. We don't believe that Africans do art just for art's sake, but African art is done with a lofty purpose. There's always something higher than just the art you see, and so for us, scholarship is a form of art. And we've even described it and presented it in such a way at AfricaLogical.com with our Panoply. But this art that we are presenting is not just for art's sake, but it's for a lofty purpose. And what we do, we create consequential reports. We engage a community through a process called community valued research. And we listen so that we might amplify community voice so that laws, policies, procedures, rules, and regulations can change, because that's when we know change is taking place. We know it when we see it and when it's written. So we do want to provide an opportunity for experts that are with us. And once again, thank you for being with us on today. We're excited to see such a robust crowd of persons that are interested in what we are doing, and we encourage you to find us. Once again, you can hit that QR code at the bottom on the right there, and you can get to africalogical.com and find all of our information. These are members of our team that are before you. We are looking forward to the work that is ahead, but our faith community consultation brought together people from all around the state of Indiana. Our community leadership board is evidenced at the bottom is a motley crew of some really great people that have determined that it's the right thing to do to work together so that we can address these systems that have the potential to keep so many people away from prosperity and away from the hope that is necessary and needed, certainly during times like these. And so we invite you to ask questions. And thank you all for this time. Dr. Craig?
I'm happy to open it up for questions. Yeah, I think it's probably better just to pivot to questions rather than starting on a new line here.
We have more to go. No.
Well, thank you both so much for that presentation. I know there are a lot of good resources that Sadina has put into the chat for people to save and take with them, and we can include these in the follow-up email that we send with the recording and the PowerPoint presentation. And you're doing such great, important work. So I'm looking forward to staying up to date with what you're doing next. Which I guess leads me to my first question as we're waiting for others to put questions in the Q&A of just letting us know like what is next for you? What are your goals and who are the partners that you're hoping to engage with most next? Just any next steps you want to share.
Well, thank you. As indicated, we have received commission, some support from the Indiana Minority Health Coalition, and we're looking to move now to disseminate the research. This Fight On 2025 document attracted their eye and their purse. But in their attraction, they also are very clear that while we are disseminating, we continue to accrue emails. We continue to create the relationships that are necessary. Our last project with the Robert Wood Johnson Foundation took us to 5 cities around the state of Indiana in the summer and fall of 2026. We'll go back to those 5, but we'll add 2 cities to the southern portion of Indiana that were not a part originally, but we'll go and have healthy discussion about health equity in general. Once again, our area is Medicaid and Medicaid expansion, specifically in HIP. And so we'll have an opportunity to talk in 7 areas. We'll have Zoom sessions and in-person sessions. We'll seek to determine who wants to be greater partner and who wants to work with us, who wants to share with us in this journey as we continue to grab information. And I think a big part of what we're doing is not just providing information in terms of health equity, and we're gleaning information from people around the state, their attitudes, their hopes, even progress that can be made when it comes to health equity. We'll determine and talk about problems that are health equity in general. But at the same time, a big portion of what we're doing is we're driving people once again to that website, AfricaLogical.com. There's a yellow button on that homepage that's a sign on to fight on. And it's important for us as this amicus brief goes through the appellate court to the U.S. Supreme Court. We don't know when it will go, but we do know that it's important for us to, yes, have individuals, but as many organizations as possible to say that not just in Indiana, but around the entire country, there are organizations that are willing to stand up and say, not that killing people by the political determinants of health is wrong, which is correct, but this call to action is a call that says we want you to, as an organization, support community voice being amplified when decisions like this are being made. And so that is, I believe, something every organization, everybody with a soul or a heart, ought to be able to say that if Medicaid decisions are being made and people are dying because of these decisions are being made, at least let the people that are being negatively impacted disproportionately have a voice during this time. And so as we go through these next months. We know there's a 27 session that is coming up, but even as that session comes up, the appeal will be to persons around the country, to people that have like mind and are caring or empathetic at this point, to put ourselves in others' shoes and then to say that we want to participate in allowing them to amplify their voice. And there just might be a voice that I have that will allow me to cheer this fight on as we continue to move toward a better day.
I want to add how these next steps relate to this goal of strategic systems engagement. So one of the systems that's very active today is not just the legislative system, but the policy implementation system. So here in Indiana, it's Indiana's Family and Social Services Administration. The big, beautiful bill includes $900 billion in Medicaid cuts. Half of those cuts are not built in by saying we're reducing the budget. They're anticipated because people will be cut from Medicaid rolls. And people will be cut from Medicaid rolls because of procedures and how the procedures on frequent eligibility reviews and work requirements are implemented. And states have some latitude in how that's going to happen. Indiana has chosen the most stringent way to implement those. So what that means is these cuts are going to be happening off the radar. People are not going to be able to follow the procedures and they're going to drop away. It's not going to be like, we're cutting. It's going to happen behind closed doors. It's going to happen silently. So that means it's really important to try to find ways to get credible data on what's happening on the ground, right? So there's an ecosystem of nonprofit organizations that support health. As much as possible, we're trying to piggyback, right, on that ecosystem. The Indiana Minority Health Coalition has coalitions around Indiana that they've spent, decades building. already there are people who have this knowledge. Already there are people who have this kind of communal authority relationship. So we've got to be working through those channels. We got to be working through that ecosystem network. And I'll just also say that the Indiana Minority Health Coalition funded our first study back in 2019. And one of the things that we appreciate is they said, why not add to your budget and do community produced videos that actually talk about people's stories and the ways that community organizations support them. So, in a sense, they gave us one of our first lessons in community valued research and dissemination. Because if you're trying to make a very public, very public rendering of people's lived experiences, that changes how you're going to do your study, right? It changes who your first audience is. And it also got us an audience with the Secretary of Family and Social Services Administration at that time. So we were able to engage policymakers. So this is one of the lessons that I think we're trying to just hammer home here is like to engage systems, you do have to think strategically about, how do they work? What influences them? What are the stories that they're working from? And so hopefully this gives some sort of examples of ways we've tried to do this.
Thank you both for your responses. And I'm going to respond to something, Ivan, that you were talking about, and it's mainly the website, because I went back and looked at it when Sadina put it in the chat. And I think it's just so beautifully laid out, especially how you have that section at the top for the call to action. And even within that, it looks like you have different work groups based on interest and how people want to engage. And I think that's wonderful. And then kind of looping in what you were saying, Dr. Craig, about the videos, like just scrolling through the website, there are tons of videos and also testimonies and also journal articles. I mean, you kind of have a little bit of everything, so many different dissemination avenues there. And Dr. Craig, speaking to systems engagement and systems alignment and working with systems partners, I mean, they all have different levers and incentives for participating in this type of project. And that is no easy feat. And before jumping into some of the questions that are coming into the Q&A, I think one thing that was coming up for me was what systems partners aren't currently engaged that you hope will be engaged that could help with this effort.
Well, we always want more engagement from our legislature here in this area. And so the ability to communicate on both sides of the aisle and to communicate really in different ways because people hear differently, people learn differently, people are triggered by different data, by different stimuli. And so that's a great question. We know that there are lawmakers, but then there are also, as Dr. Craig said, there are people that are in charge of policies and procedures and rules and regulations. And if we could, in some way, engage the system that trains people to deal with people, so that perhaps they're given an incentive to put people on Medicaid so that our workforce can be stronger and our state can be stronger, as opposed to being mall cops with the little flashlights that try to, with their little bit of authority, keep people off of Medicaid as opposed to putting them on Medicaid. I think that while we have lofty goals, and I think we think pretty good about how to be consequential with our reports, that's an area that is extremely important to us, that beyond the layer of bureaucracy, there are actually some people that have to deal with people. And our 2019 study, one of the greatest conclusions was the lack of communication, whether or not it was people knowing the advantages of Medicaid expansion and HIP, or whether or not it was the communication when people were working with navigators trying to register for Medicaid. We noticed and documented great communication barriers and even some bureaucratic hazing that takes place that keeps people away from benefits that they should get. We're talking with Medicaid about people that make $20,000 a year or less. And so the laws that are in place right now and being enacted right now are cruel. And so our job is then to fight for those that can't easily fight for themselves. But if we can do that by ensuring that their conversations that take place and shifts in policies and procedures that actually help people to get this benefit. Our governor here in Indiana, the second thing he did, the first thing he did when he came to office was he wiped out DEI, made it illegal, and took over the IU and their trustees and just that's the first thing. The second thing was to say we're going to stop advertising for Medicaid. If you stop advertising for Medicaid, and if that's your position, then what you are saying is that you don't want people to know that they have an opportunity to live. In fact, what you're doing is you're setting a process up that pushes them toward premature death. And yes, it is the people in positions and the policy makers, but there are people that are pulling the levers of procedures and policies and interpreting. As Dr. Craig said, Indiana has decided to get out in front of the federal regulations regarding Medicaid expansion. They are worse. They are more hurtful in Indiana than what the federal government requires. And so we're dealing with a heart problem, a soul problem, maybe atrophy of the soul because it hasn't been used for so long at this point. It is weak. But wherever we are in terms of how we define or describe this era, this season, I think it's important for us to be diligent and to make sure that we're creating and providing data for treetop folk, but also there's some people that perhaps can be influenced that are not in top leadership positions, but they are in positions to make rules and regulations and to change the way things are being interpreted so that people can have an advantage of longer life and longevity.
I would just quickly add to the media system, which is a bit of a mystery these days in terms of how you get media out effectively, both because some of the traditional outlets like newspapers don't have the following that they once did, but also because people are inundated, right? And so this is part of the reason why poetry, art, film are integral to the strategy is how do you break through, right? But I personally am still trying to figure out how to crack the nut of really effective communication at the grassroots level in particular. I would also add that you know the policy making system, the Indiana Medicaid oversight system, is worried about cost. There's a question in the chat about the high prices of hospitals. Affordability is clearly part of the issue here, right? And to the extent that some of Medicaid may be supporting very pricey, um, you know, approaches that maybe there are ways to sort of contain costs to allow the dollars to flow further, right? That's a tough question, but that might be a system question to try to engage, right? Is how do you make sure that Medicaid is really also affordable as well as high quality? And I think that might be a kind of system engagement that we haven't done. Partly because because you first of all want to establish the access, and when everything's being cut, it's hard to have the question about like, how do we do this more responsibly?
Absolutely. Thank you for those responses. You just mentioned or referenced the question that I was going to ask next, which I'm going to go ahead and ask and see if you have anything else you want to add to it. But from Scott, how does the high hospital pricing in Indiana affect Medicaid recipients?
Well, I mean, right, the high cost of Medicaid, I mean, the high cost of hospitals affect everybody. I mean, one, I could maybe, it's not just the high cost, it's also how costs are reimbursed, right? So Medicaid doesn't allow for accountable care organizations. Medicare does support accountable care organization approaches, right? So hospitals and healthcare providers can have some incentives to try to manage people's conditions more proactively. And if they keep the numbers down and they keep the hospital admissions down, they get to share some of that risk back, right? That's not possible in Medicaid. So there isn't that same incentive to, it's not just, this isn't just about the high cost of care, it's also how it's reimbursed, right? But, I mean, I can give like, this is, for instance, we were invited by a healthcare system. We were asked by a healthcare system, would your community board be willing to advise us about how we're trying to roll out a hospital? And we're like, okay. I mean, we showed up and they were sort of asking questions, and people were saying, we'd love to see an integrated care clinic serve this neighborhood that doesn't have one. And they were like, yeah, we can't do that because the reimbursements don't work for Medicaid. It's like, then why are you asking us, right? I mean, what do you think about the layout of the room? We don't care, right? I mean, this like there is a system disconnect, right? When community expertise is engaged here. So that's not just the high cost, but it's also what's possible within the systems given the reimbursement structures that are in play.
Yeah, and then high cost um, can be distractive. The notion of high cost. We have a $5 billion surplus in the state of Indiana. And so there's money if you want to spend it for things, right? What we've determined is that people do not want to spend money on particular things, and that the wider narrative is even more heinous because the attempt is to eliminate, right? To unalive people through political determinants of health and pushing them over borders or taking SNAP away or taking Medicaid away. It is a way not just to be mean and greedy, but it is a way to kill people. And so when it comes to money, there's money that's available, and what do people say? You have money if for what you want. If you want something, and if you want Medicaid, if you want people to live, then there's money that can be utilized in that way. And so how do we look at it differently? That if I have somebody that has been kicked off of Medicaid because of these rules and regulations, then their primary care physician becomes the hospital emergency room, right? But if I look a particular way or look suspect, now you can be questioned in a church sanctuary and a hospital emergency room, right? And Homeland Security might be called, and you might be sent to Uganda, even though your people are from South America, right? And so we're not just dealing with a financial issue here. We're dealing with soul issue, right? And the soul of this country is suspect. I'd say it's certainly gray.
Absolutely. I hate to close us out on a on such a great tone because you are doing such great work, and I think everyone here is encouraged by what you're learning and what you're doing. And I want to be respectful of everyone's time. I know we're at the top of the hour, and so I'm going to go ahead and close us out. But we have two fantastic questions that we didn't have time to address. So I'm going to email those to both you, Dr. Craig and Dr. Hicks, and see if you can respond via text. And we'll include your responses in the follow-up email that we send, along with the recording and the PowerPoint slides. So I'm going to go ahead and close this out today. Thank you so much for coming and inviting us into your world and letting us know what you're working on. And thank you to everyone for joining us. We appreciate it. And I hope everyone has a wonderful rest of their Wednesday.